sponsored by Ohio Health, represented today by Shauna Davis and her colleagues, and Bricker and Eckler, and I'll pick out somebody, Jenny Carney and her colleagues. Please join me in thanking them for their support. Information about each of our speakers is in your forum flyer, so I will provide only brief introductions. Our first speaker was named the Director of the Ohio Department of Mental Health by Governor Kasich in January of 2011. Please welcome Tracy Plouck. Our next speaker is the Vice President of Communications and Public Relations for National Church Residences. She is the parent of children with mental illness and co-leads a support group at Vineyards Columbus called Loving Someone with Mental Illness. Equally important, she is our Secretary of the Board, Karen Twynham. Our third speaker is President and CEO of Maryhaven, an organization that helps men, women, and children to restore lives when those lives have been interrupted by addiction or mental illness, and a very old friend of mine, Paul Coleman. Not that you're old, Paul. Serving as host today is a woman who has been Public Health Commissioner for the City of Columbus since 2002. Please welcome Teresa Long. So welcome, panel. Teresa, it's all yours.
Thank you very much, and thanks, Rich. Thanks again to Bricker and Eckler, to Ohio Health, and actually to the Metropolitan Club. And thank you. Thank you for joining us today for this conversation, our healthy community, the societal costs of mental health. We're glad you're here. This is really an important subject. Mental illness is a silent, lonely, and complicated group of diseases that can rob our loved ones and our families of their health, peace, and in many cases, their very lives. And it's pervasive in our country. 57.7 million, 60 million people, or 1 in 4 adults, suffer from a mental illness, from an anxiety disorder to schizophrenia. Young or old, rich or poor, no one, no neighborhood, no family is immune. A recent study by published in the American Journal of Psychiatry found that most serious mental illnesses, of the most serious, schizophrenia, the bipolar disease, and major depression, afflict 1 in 17 and cost our nation nearly $200 billion in lost earnings every year. Despite its prevalence in our society, mental illness continues to carry a stigma, and many people suffer, sadly, in silence. The results of untreated mental illness, frankly, can be devastating. According to the Centers for Disease Control, 80 to 90% of people who commit suicide are suffering from a diagnosable mental illness. People with serious mental illness also live 25 years fewer than the average, mostly due to the health complications that accompany this disabling disease. And frankly, as I was preparing for this, people asked me, what about that connection between violence and mental illness? So let me quote a colleague who was just in the paper, and thanks to the Dispatch and others, there are lots of talk about mental illness right now. But I think a most important thing to keep in mind was and is that most people with mental illness are not violent. And most people who are violent are not mentally ill. But indeed, there can be a convergence. And that, of course, is when we see and hear all too frequently, just recently, untold children, adults, whether they were going to school or visiting a movie theater, happened to be, unfortunately, in the wrong place at the wrong time. Many people with mental illness cannot get the help they need, and in many cases, desperately want. Access to care is limited. We hear that our current mental health system is underfunded and overwhelmed. Is it? And yes, are there enough physicians? Are there enough beds? Are there enough of everything to support patients who have increasingly complicated needs? Long wait times, insurance disparities, and of course, billions of dollars of funding cuts that may be coming our way. So with that, we have this esteemed panel, and I have been invited to be a host, not a moderator, so I may get to jump in as well. So with that, again, Tracy Plouck, Paul Coleman, Karen Twynham, thank you for being here today. So I'm going to open it up with them with a question that is wide enough and broad enough for everyone to jump in, I hope. And that would be, what are the shortcomings of our mental health system? And of course, the challenges that are facing people with mental illness in our community. So I'm going to leave it up to whoever wants to jump in first.
Well, good afternoon, everyone. I'm Tracy. I hear reference sometimes that the system is broken, and I refuse to use that terminology because this field is about recovery and it's about hope. And I think that if we start with negativity, then we're not really focused entirely on a solution. And so we've got a lot of different kinds of initiatives underway to move toward a stronger system. There's been a lot of atrophy in funding, as Teresa mentioned, over a long period of years in this area, but I think that there is renewed conversation in the last few years about the importance of having treatment available and accessible. But I just want to start today by sharing a little bit about our system within Ohio. We are a partnership administered system between 50 county boards of mental health. Some of them transcend up to 6 counties, and the state, and then we've also got federal dollars in the mix. In some places, access to care is very limited, and in some cases may not be available at all if you don't have a payer source. And that's, due to the funding realities. Sometimes you've got difficulty bringing providers to a particular area if it's rural, as an example would be child psychiatry. And so you've seen one community in Ohio, you've seen exactly one community, and there are no standard set of challenges. But with that, I think one thing I can't go a day without talking about is the governor's proposal to extend Medicaid benefits to childless adults up to 138% of poverty. If you have an individual who in many cases could be working, who makes less than $16,000 a year, it's very difficult to connect with a private payer source for insurance because it's unaffordable, or maybe it's not available through their employer, or maybe they're not working based on their needs. And so the governor's brave proposal to extend coverage for these folks not only provides access through a payer source for those services, but it also brings in physical health care as well. And many times there's been many advances in medicine in this area of science, but there are side effects. And sometimes particular medications that work well for a person's mental health recovery create challenges with obesity or blood pressure or other physical health conditions that also need to be treated. And so if we want to have stronger families, stronger employees, it's important to make sure that there's a connection to health care. And this is not been received, with 100% excitement by the House and Senate, to say so diplomatically. But the governor is undeterred, and we will continue to try to work towards some kind of resolution in this area because it is critical. And also, just to briefly, I mentioned we have 50 different boards funding mental health services around the state. If Medicaid comes in as a payer for things like counseling and pharmacy and other really critical sources, the boards can take dollars that are currently being spent in some communities, if they're available, and direct them to other kinds of recovery supports, like housing, which is very important, employment counseling or employment readiness, prevention partnerships with the schools. And so I think our whole challenge is to figure out how we can go upstream and not just intervene with those individuals who are in most crisis because that's all the resource we have. But if we connect people with services earlier, that actually helps them be more well because you don't have to decompensate into a crisis situation. So it's better for people, and ultimately it's better for taxpayers. So I will open with those statements.
I said no opening statements.
I'll open the dialogue. How about that?
So with that, actually, it's very helpful. I mean, you've just shared with me it's not broken. There may be shortcomings. There's opportunities to strengthen. I'm hearing that. So let me ask Paul and Karen, and we aren't going to keep it going up and down the line. I promise you that. But we'll let Paul go next.
Thank you, Doctor. I'd like to second really what Director Plouck has said. The system needs to be better, but please understand, in no sense of the word is it a bad system. It is an inadequate system. And as Tracy has told us, it depends very much on where you live. Maryhaven does business in 9 counties. We do business in 2 of the 6 contiguous counties to Franklin, even though Franklin, of course, is our principal place of business. In Franklin, we are particularly fortunate to have the leadership of the Franklin County ADAM Board, Alcohol, Drug, and Mental Health Board, which plans, evaluates, and funds a network of 35 nonprofit funders. And Tracy and I have been talking about public behavioral health care. There's a whole challenge in private behavioral health care, which, by the way, was the subject of a wonderful series on WSU Radio Mandy Trimble did. But in terms of public behavioral health care, the services that someone gets for addictive or mental illness depends on where they live. And we are fortunate in Franklin County. Last year, ADAM-H invested nearly $70 million in addiction recovery and mental health care and prevention services for children and adults. And I want to close my opening statement. But see, I'm a lawyer. I get to make an opening statement.
They're already rowdy.
Yeah,
what can I say?
I'm out of control. I'm sorry, Doctor. I want to close it by saying that out of that $70 million, which doesn't fall from the sky, 75% of it is because of you. You are the voters of Franklin County. You have made a decision in enacting levies for the ADAM Board to provide 75% of that money that ADAM distributes to care for men, women, and children with addictive and mental illness. And I want to thank you.
Well, thanks. And of course, I guess Karen gets an opening statement. Not really. But Karen, again, your thoughts, obviously you've got some special ones and very personal ones about our mental health system, both the shortcomings and of course the
I've kind
challenges.
of lived the shortcomings of the mental health system, and while I appreciate what Ohio has done and is going to do, I would ask you to consider if somebody stood up here and told you that there were places in Ohio that you could not get treatment and there were places that you could not get money for the treatment and the disease was cancer, what would you think? Mental illness is very often a brain disease. That is what it is. And there is a great discrimination against the people who have it. I believe strongly that we need to learn from our friends in the gay community, and we need to speak the truth, and we need to be more visible so people will understand what the problem is. One of my fellow persons in the community of family members with mental illness is our governor, John Kasich. His brother has a very serious mental illness. And he recently spoke and said, you need to let people know what your life is like. It's not something that just happens to somebody else in some other place, in someone else's family. We shouldn't be ashamed or embarrassed to let our friends and neighbors know. So I'm here to let you know. I have 2 children. I was married to a person who developed atypical psychosis when he was 30. I joke that he couldn't even get psychosis right. So and it lived on from there. My daughter, her name is Sarah. She writes under a different name, so I feel very comfortable talking about my children by their real names. Sarah started to get sick when she was 3 years old, and we went into therapy to see what on earth is wrong. By the time she was 7, they said something really is wrong here, and she was one of the first children, I believe in the world, diagnosed with juvenile bipolar disorder. She had a really rough time growing up. I have to say the school system didn't help. I ended up pulling her out and homeschooling her, and I was the parent at orientation for college that asked all the questions about the refund policy. But she made it through, and she is now 31 and a writer in New York. She's had ups and downs. She had a hospitalization last year that was very serious. But she's had ups and downs. And just as we thought things were going to go okay, we got a telephone call about my son, who was then 19 from his former girlfriend, and we took him to the emergency room, thought he was on drugs, and when that drug scan came back clear, it was the worst moment of my life. I knew he had schizophrenia. He is now 27 and lives in permanent supportive housing, which is the greatest blessing we've had in the treatment process.
Okay, that makes it real, doesn't it? So thanks, Karen, for sharing that as well. And actually, I'm curious, because you're talking about the stigma and other chronic diseases. You mentioned brain disease, but yes, whether it would be HIV in our GLBT community and their allies, breast cancer and the allies, how important that is in addressing just the stigma, let alone the services and the capacity after that. So let me just ask, Paul and, well, actually all of you. So what is it that we can do here to address these issues? Take it out of the closet, so to speak, to address this.
Yeah, Teresa, I'm happy to answer that question. I've been in the business for about 30 years, and I've seen the understanding and thinking about behavioral illness evolve. And I am firmly convinced that the science is very clear right now. Both addictive illness and mental illness are diseases of the brain with behavioral manifestations and implications. Now, my proposition to you here this afternoon is, please understand that this is very similar to other diseases which we have routinely destigmatized. For example, diabetes is a disease not of the brain, but of the pancreas. Does it have any behavioral implications? Ask an ER doctor. When the patient comes in with the bracelet on the gurney, and the doctor says, "What happened?" "Well, I ate cake." "Well, you can't eat cake." "Well, I like cake." How is that different from someone with bipolar saying, "The mania is so great that I don't want to take my meds"? Or someone who is addicted to heroin who says, "When I stop using it, I feel so terrible." It's not. And if we can all understand that and tell our associates, family, and friends that we're talking about a brain disease with behavioral implications, both in terms of diagnosis and management, then I think we'll go a long way to eliminating stigma.
I appreciate that. Tracy, do you want to add anything? Because I think this is one of our key opportunities to all learn this afternoon, is to think about, it's really about all of us. So thanks, Paul, for that comment. Tracy?
Yeah, I feel really strongly that money is not ever going to fix everything. And so since 2006, I have been a volunteer at my local crisis line, the Delaware Helpline of Delaware and Morrow counties. And that is something that anybody in this room can do. You can volunteer. Thinking about a helpline specifically, if you don't want to work on a crisis line, you could help with a grant, or you could help with other sorts of volunteer opportunities. There's something that everyone can do that doesn't involve money. It might just involve a very moderate piece of time, because I think that this is a community destigma, support initiative, and there's something that everybody can bring as far as a gift to the table.
I appreciate that. And actually, we don't know what any of them are going to say. Karen, you mentioned that you serve as a co-lead or facilitator of a support group. What kinds of things come up there that would be helpful to us to think about how to address the hiddenness of mental illness? Are there things that have come from the group that you could share?
Well, most of the things said, everything said is confidential. I can tell you that we do get people in crisis who literally don't know what to do. We have people whose children are tearing pipes apart at night trying to find where the noises are coming from. People with young children who are really, really ill. And I think one of the things that we could do is to improve awareness of where you go for first steps. Not only through public communications, which is my field, but also in the school systems. There have been some efforts to try to increase the knowledge of teachers when they're actually seeing a mental illness in front of them and what to do, and to get that information to the parents. People are not sure what they're seeing. They're often in denial about what they're seeing. It's to be told that, your child has schizophrenia is a really devastating thing, and they don't want to believe it. So it's a process, but still we have a lot of people who really don't know where to turn.
Right. And actually, you're just making me think about how important it is for us to tell our stories. And I know that there are multiple agencies in this community who are trying to move forward campaigns around destigmatizing. So indeed, for all of us to take that up and think about how could we share that in our workplace. Some of us have very active employee assistance programs, et cetera, because again, 1 in 4 means it really is about all of us and our families or our neighbors or our colleagues. So there are people who will be needing assistance. So thanks for that. I appreciate that. So now I know that the system isn't broken, but could be strengthened, so I appreciate that. But again, I am wondering about this issue of providers, and this issue of, okay, it's not that there's not enough money, though Medicaid expansion would clearly assist this, providing more people access in different ways. But what about the health professionals? How are we going to respond to that as far as there are not enough physicians, there are not enough this and that? And Tracy and Paul, I know you're right there on the edge of both thinking about this. What are we going to do with that? And I think there are some models that I'm hearing about. So where are we in Ohio as far as trying to address the availability of services?
One thing that I found very interesting in my travels around the state, Summa Healthcare up in Akron, was they're training their residents for physical health, the doctors. They actually have them sit with the psychiatric residents, and they're operating sort of in a bullpen environment. And previously, it had been siloed. And you're talking about the same person who in many cases has diagnoses that, transcend both physical and behavioral health. And so I think just from the very beginning, taking the opportunity to recognize the multiple circumstances that a patient might have and emulating that in different sorts of medical schools. We are trying to work more assertively with the med schools around the state now to try to provide some assistance on different public health fronts. And think about what are the gaps in a particular area of the state and how can we shore that up. But, candidly, there's not going to be enough psychiatrists in the pipeline. And you need to make sure that among the nurses there are enough who want to go into psychiatric nursing. So this is going to be a continued problem. And while we're trying to sort that out, I think having access to more things like telemedicine, where let's say we've got a program underway now all around the state, particularly in rural areas. If you have an adult or a child who has both intellectual disability and mental illness, and you don't have specialized psychiatry in your area, sometimes you're driving 3 hours in order to get an assessment and get ongoing support. So we have actually partnered with Wright State to do telehealth with a specialty psychiatry unit to provide that resource all around Ohio. So I think it's really identifying what the specific challenges are and then figuring out with the community how can we address this. And it's not a one-size-fits-all.
Actually, you're pointing out, I had no idea. Paul said I was an expert. That was why I was on the panel. I'm like, I really don't feel an expert. And that's really interesting to hear about this, Tracy, because actually I often turn, and I think many of our larger organizations have employee assistance programs. I am constantly going, okay, I know that I need to refer somebody. And Karen just mentioned, so it's important for us to know the next steps. And many of us do know that access and net care access is a first step for some. It's not always the first step. But how interesting, and how do some of us learn about this Wright State, or maybe all of our health providers who are actively working in this area know about that? I mean, somehow it is about connecting dots, both for providers, but really for patients and families.
Dr. I can really not solve the problem of physician shortage. I think we are going to see it become acute with the implementation of the Affordable Care Act. I think it will be even more acute in the area of physicians who are trained and certified in psychiatry. Maryhaven has been on a 5-month search for additional psychiatrists to help with some of our growing programs. It has been a challenge. The use of physician extenders, I think, is important. As Tracy mentioned, the use of nurse care practitioners, physician assistants. I think, frankly, we have a better chance in our community of getting more men and women to go into the allied professions like nurse care practitioners, like physician assistants, than we do in persuading folks to go through, as Teresa did, that course of study to lead to the MD or DO degree. It's a long slog, and sometimes the rewards are simply not commensurate with the investment of time and money. The other thing I'd like to quickly say, Tracy has mentioned the fact that we need to do a better job in the healthcare business of integrating behavioral and primary care. And I'm happy to tell you that Maryhaven in our community is part of the solution to that, along with, as Teresa knows, an agency that she's very familiar with, the Columbus Neighborhood Health Center. We just recently opened a separate point of access clinic in Maryhaven's main facility on Alum Creek Drive, which is staffed by primary care physicians and nurses. Our patients at Maryhaven who come to us for behavioral health needs can now literally walk down the hall to a place where they can see a doctor for high blood pressure, for diabetes, for the other problems that frankly become manifest once they start getting sober and come down from their mental illness. So far, we've accounted for over 1,000 patient visits for primary care at Maryhaven just since January.
I believe that 55% of psychiatrists are 55 or older.
Mm-hmm.
So the shortage is real. My son was on an 8-month waiting list to get in to see his psychiatrist. For those of you that are here in Central Ohio, the tip in our community is Buckeye Psychiatric, in which because they don't take insurance, you can get in a day or two, because it really is a problem when you're trying to get medication, and you need to get medication quickly. Maybe your person has come into a window where they finally realize, I do want to get back on my meds, and then some family doctors, my family doctor was not comfortable with my son once he was diagnosed with schizophrenia and said she wouldn't see him anymore. So you have to go quickly, and you can either find somebody, a psychiatric nurse practitioner, if you can find somebody like that, somebody who doesn't take insurance, go to Netcare, or you have to go to the emergency room. And overall, we're trying to drive down those costs. But that's basically what you need to do, and part of it is because of the shortage of psychiatrists.
And just to note too, we have a toll-free bridge line at our department that helps connect people from all over the state with services if they've got questions. And it can be sort of triage to local resources. But if you go to the front page of our website, you'll see that if anybody's curious.
Well, that's helpful, because I didn't know that. And actually, I hear a lot about dilemmas that people face, residents and providers. And the issue around mental health they've been long-standing, frankly, in this community, and I think probably across the country. But it feels as if we are under mental health already. And then to be bringing in what we think will be more people, we hope more people who will have insurance, it really causes a dilemma, for our hospitals. We have people who are stacking up, frankly, in emergency departments, because as Karen mentioned, sometimes that is the only option if there is an acute situation that feels unsafe, and that really is the right thing to do. But and I know our hospitals actually try and connect, if not every day, and I'm looking to some of them.
Every day.
I think they call each other every day. Who's got a bed? Who can we put someplace? Because again, they're very committed to trying to best address the needs, of the patients that they have, and that's really collectively. So I appreciate that. I also think that the new model, and I think it is a relatively new model, of integrated health care, and the language that's been adopted here in Ohio is the health home, and again, that's not the same, but connected to really the patient-centered medical home. But this health home of integrated mental health, behavioral health, and physical health is really trying to get primary care physicians and others to practice, to be aware of both sides of the mental and physical health issues. So they too can really be, again, at the top of their game, addressing the issues. If they need to refer, great, but they should be screening. They may well be able to treat. And it sounds like Karen's had some experience with that as well. So again, the health home concept, if you're not familiar with it, I think it's a really important and valuable thing that's being driven here, and I think that should help as far as providers. I'm looking to Tracy. You think that'll help?
Yeah. A health home is not somewhere where you live. I just want to make sure I say that every time. In Ohio, community mental health centers that elect to participate, it's voluntary for the center, can receive a special payment rate per person that basically covers some of the consultative costs to connect the individual they're serving to physical health care. So the community mental health center builds its team. It could have a pharmacist, nutritionist. It has to have primary care. But the thinking is if we can connect folks sooner, you can avoid some of those chronic conditions that are unmanaged in the long term. This is not an attempt to save money in the here and now, but rather really bend the cost curve years down the road. And just to share a couple of examples, we've got 14,000 people enrolled in health homes for Medicaid in 5 counties right now, and will be statewide this coming October. But I've heard stories where they saw an 11-year-old boy in the mental health center, and he'd never been to the dentist before, and they were able to connect him with dental care. A woman in Cleveland who was caring not only, for herself and struggling with mental illness, but she was caring for her husband and her mother, who were very, very chronically ill with physical health conditions, and they were able to get her treatment that she'd been unable to access because she didn't have any health care. She was receiving safety net mental health services, but had no access to surgeries that she needed. And so it's really been a life-saving approach, I believe, in some circumstances already. And so we have data that show in Ohio and nationally, people with mental illness die 25 years earlier than people without mental illness. Well, it's not because they're dying of mental illness, they're dying of physical health conditions that are untreated. And we absolutely have an opportunity here to change the course.
So that's what a health home is. I apologize for the jargon. Really important, and actually there's now new language about a health neighborhood, and I'm looking to some of my colleagues. That's really not what we think about in public health. We're always talking about healthy neighborhoods and healthy parks, but a health neighborhood will be really what's kind of described in the Affordable Care Act as far as the accountable care organizations that are going to try and get us from place to place. So again, our care is better coordinated. So if you haven't heard that term, stand ready, because you'll probably hear about a health neighborhood. So let me just ask Karen, because I've been wondering, here's a big forum, and we've been talking both about stigma, about the kinds of things that we should be thinking about. What kinds of advice do you give, whether in your support group and as you travel our community, what kinds of advice do you give to moms and dads and family members who suffer from mental illness?
One of the things we tell people is that this is a no casserole disease. You're going to feel pretty lonely. It's not a disease where people are going to come over. My co-leader, for example, got cancer after her son died from bipolar disorder. And she was so mad when people showed up with casseroles and flowers when she got cancer, because she thought, this is nothing compared to what I've just been through. So you are going to feel very lonely. The people I've seen that have gone through this really show you what real love is, particularly the mothers for their children, and they show you what courage is. We also try to tell them about 5 basic things. The first is that diagnosis is difficult. You'll go to different doctors and you'll get a different diagnosis. It's really hard to say what it is. It is going to be hard to get help. There will be waiting lists, there will be problems yet, so it will be hard, and it's hard to get a really good case manager. When my son originally got into the community health system, he was at Southeast, and his case manager told me, I have 140 people on my caseload and 139 of them are homeless, so basically I'm not going to pay any attention to your son at all. It's pretty rough. It's also that you need to make friends with a case manager to understand how the system really works so that you can get help when you need it. And that it's difficult to keep people on their medication, but never give up hope. When my son got into permanent supportive housing, he was on a waiting list for 3 years, and it was like a light went off for him. He actually had hope for the first time. And he quit drinking, he quit smoking, he's trying to do a 5K, he's thinking about going back to get into a vocational rehab again. So there is hope. It just sometimes takes a lot longer than you hope it will.
Karen, the hardest calls I get, and I get hard calls, are from parents of adult children with behavioral illness. Because one of the things that is critical in behavioral health, as well as in primary care, because they're not different, okay, is patient compliance. Patient compliance. primary care, if you've had a heart attack and you keep eating the wrong foods, keep smoking and don't exercise, you're going to have another one, right? Behavioral health, if you're properly diagnosed as schizophrenic and you don't take your meds, you're going to have problems. If you're a properly diagnosed alcoholic and think you can have just one drink on the way home, you're going to have problems. So there are behavioral implications to both primary and behavioral health. But what I have to try and tell the parent is, as much as you want your son, who is 42, to come into detox and get better, until he at least makes the call, there is nothing we can do. Don't lose hope, but it does require patient compliance.
And one of the most heartbreaking things, I think, just building on what Paul said, just thinking about my volunteer experience, sometimes get calls from someone who is ready to come into treatment now. It's Wednesday night at 10:30 and I am ready to go now. Where can I go tonight? And there isn't anywhere, you know, because there's a shortage. And so trying to match people, whether you're talking about detox or whether you're talking about housing, candidly, when people are ready with what's available, where they are on wait lists, I mean, it is, that's, I think, one of the inherent tragedies here. Just the inability to make connections when people are ready to connect.
Thanks. So this is my favorite part of Metropolitan Club Forums. So this is your opportunity. So we'd love for you to come forward. There is the one microphone here to ask your questions. Again, no big statements. You don't get an opening statement. They didn't either. But we'd love to hear your questions. And since I don't see anyone yet, let me just ask this, since I think we've been around this, or maybe we do have a question. So we'll let Jane go first.
Well,
So
I'll always
great.
be willing to break the ice. I'm Jane
Great.
Scott. We talk about mental disease. Is there a cure, or is it really treatment we're talking about? This is something I'm not quite clear on.
In my judgment, both mental illness and addictive illness are diseases like diabetes. They cannot be cured, but they can be managed very successfully through treatment.
Chronic conditions. Absolutely.
Absolutely, Doctor.
Right.
Yeah.
Hi there.
Hi, Gail Thomas. Paul, listening to you, it reminds me so much of the collaborative and the heroic work of so many people in this community to make mental health a priority and have stuck with the issue. It goes beyond that, I know, but when listening to you, I can't not forget all of that energy that people have put into it. The other thing, I work with the Alzheimer's Association and I do advocacy, and the stigma issue is a huge barrier to communication, to asking for help. I mean, so many of the things that you talk about, that it's brain health, it's not aging, it's brain health, that I'm looking forward to a discussion when the neurological senses of the medical world get integrated with more and more in the same way that we've been talking about it. Because when you say Alzheimer's or dementia, it's here, folks. It's me, it's you, it's I. 1 in 3 of us know somebody. The people I work with in advocacy, we're talking about 45-year-olds who are wage earners and caring for their families. We're not talking about my grandmother at 90.
So do you have a question?
I do have a question. Sorry. The question is, when will it become part of the broader discussion? Thank you.
Good. I led you right to it. Thanks, Gail. I'm sorry to cut you off. So when will mental illness or other kinds of brain health issues become a part of the general discussion?
I feel like it's part of the general discussion now, and maybe it's because I talk about it constantly, but I mean, in the media, there is a lot of focus now, and in some cases, I think that it's very unfortunate related to tragedies that may or may not have actually been engendered by an individual's mental illness. In some cases, we will never know. But I think that that's brought it to the forefront more in recent years. And I think also, I was actually just earlier this week in a meeting with all the mental health commissioners of the states, and we had a session on different kinds of disasters that occur. And I mean, there are Colorado wildfires right now. We've got hurricanes. We've got different things that cause trauma. And sometimes people need help adapting to their responses to different kinds of trauma, even if they don't have a diagnosable mental illness. And I think that's another way that mental health is coming into the forefront, into the discussion these days.
Once again, I'd like to remind us all how fortunate we are to live where we live. In this case, it's the state of Ohio. I've lived in Ohio all my life. I've known most of the men and one of the women, there's a quiz for you, who was a woman who was governor of Ohio for 2 days.
It was 11.
Yeah, it was 11. Director has corrected me, she knows. But I've known these folks, and I've worked for one of them, and we have never had the level of public discussion about behavioral health that we are having right now, right here, not only surrounding the budget, but surrounding other issues pertinent to behavioral health. And there's one reason for that, and that is Governor Kasich, who, as we have been told, whose life has been touched. And he is a powerful advocate, and he is doing the best job he possibly can do to enlarge access to behavioral health services. So we're fortunate.
Thanks. Yes.
Yes, my name is John McKnight, and I suffer from mental illness on a very low level. I've witnessed mental illness on a very high level, and what I deal with is very manageable. It seems like there's been an awful lot of, press, commercials, things like that in the last 10 years or so, bringing a lot of attention to some lower level mental illnesses, which they're very valid and they count, but it seems like they're probably bringing a lot more people into diagnosing a lot more people with mental health, maybe than mental health issues than maybe were diagnosed 10 years or so ago, with things like, ADD, things that, you see the drug commercials every day on television. Has the influx of diagnosed mental health issue people put a burden financially on the mental health system? I don't say that because I don't think they should come forward to get treatment, but I've got to wonder, are a lot of doctors really busy right now dealing with patients that, simply weren't coming forward 10 years ago or 20 years ago, and maybe that's caused a financial strain on the system?
I can take a shot at a first response here. I used to be the Medicaid director, and it was always interesting when a new pharmacy item came out in direct-to-consumer advertising, you could see the uptick in the utilization of that particular drug in the data. And so I think that in some cases, advertising or, focus on, as you, characterize, not as acute circumstances for folks. I think that there has been more acknowledgement of that over time. But the community-funded system, the public system, is one that continues to be very focused on individuals with very acute needs, in large part, just because there are limited resources and, the goal is to put the money where it is most needed. So, crisis services, housing for individuals who are chronically homeless and struggling with mental illness. And so I think there's actually a gap in services for folks who don't have a payer source today, who don't have insurance, to access services because the waiting lists are long. I mean, there was discussion about the wait time for psychiatry, even when you have a significant challenge. So just, to go in, I think it's probably more challenging in some communities if you are not as acutely ill as others. Do you guys have reflections on that?
I think that's true. One thing I do want to say that has been helpful is when people who have situations with obsessive compulsive disorder or whatever and have learned to manage their symptoms, very often they can be very helpful to people who have the even more serious illnesses by providing practical information about how they do it. So I would encourage people that have learned things to share them.
I Actually, that's
Thank you.
a great point. I have 2 points to make. One is, and actually, Karen, it's about allies sometimes. And so obviously, as the diagnoses are made more frequently or more commonly, it expands the pool of affected persons and hopefully families and neighbors who will talk more about it. The other that's, I think, very relevant today and really in the last 2 weeks, there was just released a new DSM-3, the diagnostic and... Five. I'm sorry.
Yeah.
I went to school under the 3. It's a 5. A DSM-5 just got released. And actually, it was interesting because a lot of people are reflecting about what happened the last iteration, and that's when DSM-4 was released. And that actually had a lot to do with Asperger's syndrome being named, and lots of other things got named, and now they believe that that's really what started a lot more conversation, diagnosis, treatment, et cetera. So it's not clear to me what, some of them have been separated out in the new DSM-5, so what that's going to mean into the future. But again, it probably has broadened the conversation, for sure. Yes?
Hi, Becky Westerfelt with Huckleberry House. I was so touched to hear your story about your children, and I'm interested in what we're doing at the state level to talk about that very vulnerable transition age youth or young adult, whatever label you want to put on them. It seems to me that the youth serving community, if you will, and the adult serving community have evolved very separately. And if you are poor or you don't have a family advocating for you, you fall through this horrible crack until you become severely mentally ill. So I'm wondering what the state of Ohio is doing to bring those two pieces together.
I'm trying to think here. One, I think, very front and center challenge for a transition age youth is the fact that when they turn 18 or 21, if they're in foster care, they lose the access to a lot of services that they had when they were, characterized as a youth. Medicaid being one of them. And so I think, again, going back to if we're able to expand Medicaid in this state, that could provide a treatment sustainability for some of these young people who otherwise would lose access to having that consistent relationship with a treatment provider. So that would be number one, and that's a huge piece of what we're advocating for right now. We are actually taking steps to support a number of locally led initiatives around transition age youth. Different parts of the state have different priorities in this area and different needs that have been identified. So, for example, we had some hotspot funding that we asked communities to work together and make some targeted investments in things that they found lacking. Montgomery County and Butler County came together and they put together some housing for youth who are of transition age and paired that with some employment supports, kind of soft skills. A lot of people who are experiencing these kinds of challenges, maybe were homeless as teens, don't have the eye contact or don't have the kinds of skills that we all take for granted when you're trying to find a job, and you're going to have to be taking care of yourself now. So trying to support efforts like that. We've got work underway on the at the state level, looking at how we can be supported from a kind of a leadership opportunity for youth who maybe want to become peers and assist other people in their journey, and also like a prevention cadre for youth, and building leadership skills that you can then role model good behaviors with other people of your age as well. So those are some examples that we have at this moment, but really I think that we're trying to support different things that our local partners are saying this is a priority where we need a little bit more assistance.
Thanks. Paul, did you want to make a comment, or Karen, about services? I think they're so important at this transition, and a lot of diagnoses are just made at that time. Anything here in Columbus and Franklin County, or?
It's interesting, Teresa. Becky and I were in a meeting about a week ago at the Columbus Foundation where this issue was discussed, how to best help these youth who are transitioning into adulthood. I think there's a lot of work to be done. I think some of it will involve increased funding because, as Tracy's pointed out, once you reach majority in this state, you are no longer categorically eligible for Medicaid, which has funded a lot of this support. But I think there are probably some local solutions that we can work on. It is a national problem. I just guess I feel strongly after having lived in this community for, well, I know Rich Terapek, so you know how long that's been. I just think that local solutions are a lot better. And the government that is closest to the people tends to work the best. So while I'm hopeful for things like the Affordable Care Act, certainly hopeful for Medicaid expansion, I think there's a lot we can do here in Columbus and Franklin County, and I have faith we'll do it.
Well, with that, I want to both thank Karen, thank Paul, thank Tracy for coming today. I tell you, I think we've all learned something. And again, it is about connecting dots, both with our neighbors, our colleagues, our community, because there are going to be, and there need to be solutions, solutions that help people, all of us, right, where we live and play, we hope to play, raise our families. So again, these are really important issues. I encourage you to be open to continue the conversation and support those who have some of these issues we've been talking about. So with that, I'm going to turn it back to Rich Terapek.
Thank you,
Rich?
Teresa. Continuing the conversation is what this organization is all about, and we really thank all our panel members today for highlighting some of these issues, particularly the personal aspects of all of this. It's touching. It is also encouraging that the conversation is increasing. And I think with the governor's efforts and others, we'll hopefully keep this drumbeat going until we can address